My name is Karen Schalander. I'm the Senior Research Advisor at Malaria Consortium. I'm based here in London since the last 7 weeks or so. I'm kind of giving technical support to Malaria Consortium's research portfolio, in particular to research that we do on maternal and child health and M-health. And I've been with the organization for about 4.5 years now. I started in Uganda in the Africa Regional Office as a program coordinator for a multi-country program that was for a project called InScale, which was aiming to identify best practices and innovative approaches to increase motivation and performance of community health workers. And the program was or still is, in Uganda and Mozambique. And I've been asked to chair this session, which is on linking the community to the health system, and which will cover areas around Malaria Consortium's work in trying to reach those populations that are at most risk, the hardest to reach, the most vulnerable populations, and making sure that the care, the delivery of services is not done in parallel programs, but building into the existing systems and making sure that there is quality and sustainable services delivered to these populations. And the presentation will be given by our senior public health specialist in community systems, who's Helen Cunahan. So she will give an overview of this area in her presentation. And we will then have a panel discussion similar to the first session. And Helen she has a master's degree in clinical parasitology from the London School of Hygiene and Tropical Medicine. And she previously specialized in diagnostics when she worked at LSHTM. And she also did operational research in her time with Médecins Sans Frontières. She joined Malaria Consortium in 2005, initially as a public health specialist and coordinator of the DFID-funded COMDIS research program consortium. And between 2009 and 2013, she was based in Maputo, Mozambique, where she was the regional coordinator of our integrated community case management program. And currently, she's based in the UK as a senior public health specialist and focusing particularly on community health systems. We also have a panel of experts sitting next to me who all have a lot of expertise in this area. First, we have Nicola Cudge, who's the health advisor in the policy division of the UK Department of International Development, DFID. She's been there since 2009, and her policy portfolio includes malaria, tuberculosis, and polio, and she has previously worked with Merlin and Save the Children UK. She's worked in countries like DRC, Sierra Leone, Burundi, and Sudan. And before moving to the Save the Children's UK London office in 2006, she was working as a health and fragile states advisor. And as part of this role, she also worked on ICCM in fragile states. Then we have Dr. Kolawole Maxwell, who's a community health physician with over 2 decades of experience in planning and management of health activities at community, facility, and policy levels in Nigeria. His core expertise includes primary health care, including patient management, health system strengthening, and health sector reform. He joined Malaria Consortium in 2008, and he was the deputy program director of SUNMAP back then, and he was later promoted to be the program director. And in October 2012, he became the first country director for Malaria Consortium in Nigeria, and he's managing the country office there. And then last but not least is Dr. Franco Pagnoni. He's a medical doctor from Italy and with a specialization in tropical medicine and community medicine in developing countries. He has lived and worked over 20 years in Africa as head of several public health projects for the Italian corporation, like Zimbabwe, Mali, Burkina Faso. And between 1993 and 1999, he was the head of technical assistance program to the National Center for Malaria Research and Training in Ouagadougou in Burkina Faso. And he joined WHO in 2000 first as an epidemiologist to the malaria unit in the regional office for Africa, and then at 2003 he became the manager of implementation research and community case management at TDR Geneva. And then in June 2012 he joined the WHO Global Malaria Program as the focal point for integrated community case management for malaria, pneumonia, and diarrhea. And he has extensive expertise in malaria control and operational research in Africa. So now, Helen, over to you.
Okay, thank you, Karen. So this is going to be really a short presentation to start the topic, and it's a snapshot of Malaria Consortium's experience in health system strengthening and how we've been linking that with the community as well. So hopefully, Neil, this will resonate a bit with you. I think it's already been said very clearly, we are all aware that health systems are not evenly, the services are not even, and certainly the further away you are from the centre, the harder it is to get decent health service. This is a fishing community in rural Zambia. So from the very beginning, really responding to this, it's been a core principle of Malaria Consortium to look at health system strengthening and to work in that area. And in more recent years, we've really scaled up what we've been doing in terms of extending that approach and that how to deliver that service right down to community level and how to ensure at community level that it's something, it's quality health care. If we look at the progression, how it happened in the organization, so the areas that we've really focused on in our health system strengthening through our program, are all here, mind the pointer. And sorry for that, I always have problems with these pointers. And Andrew Collins just reminded me, in fact, that everything that we've done in terms of health system strengthening has always been the approach of responding to the country's need. So really looking at the reality before we got started. So all of these areas are typically areas that need support within a health system. So our first program, Clover, James has already mentioned, it ran for 7 years in 4 countries, including Uganda, Mozambique, Zambia, and Ethiopia, and certainly addressed many of these, not almost all of these areas, including looking at how things were linking with the community as well. So that started in 2004. In Uganda, in 2004, we also became partners in a USA program called Uphold, which was very much cross-sectoral. It included education, had a strong HIV focus. And our work in that was, again, health system strengthening, looking at the market for nets, mosquito nets, and also evaluating the first pilots of home-based management of fever. Also in Uganda, from 2005, we had the DFID-funded program, which we call Drugman, which was working with the National Control Program, Malaria Control Program, at the time where they were changing the policy from chloroquine and SP to ACTs. So again, the same kind of approach, looking at supply chain management, building the capacity, developing the training, but also looked at the private sector and training private sector providers in that program. As mentioned already, we have our large SUNMAP program in Nigeria, which started in 2008, working again with the National Malaria Control Program, but looking at all and focusing on all these areas of health system strengthening, including looking at the community. And just to say, most of these programs also have an operational research component. So this research very much looks at what we're doing, looks at ways and researches ways how the delivery can be done more effectively and how we can learn from that. And we've also had the opportunity to have some DFID-funded RPCs, COMDIS, that then became COMDIS HSD, that's worked in partnership with these programs. And a good example of that was COMDIS worked closely with the Drugman program to assess the feasibility, the acceptability, and the performance of malaria RDTs in Uganda at the time when the ministry was looking at changing its policy to include RDTs within the diagnostic strategy for malaria. So that was where we came from, always had a community element, but as I said, the community element has become stronger in the last few years. So the progression really has been, if you look at case management in the community, we were very much involved from the very beginning in Uganda, home-based management of fever, as James showed you. Then we were building on that. We were, through the Drugman program, we piloted the inclusion of ACTs at community level. We included then RDTs as well in Uganda and assessed their performance in Zambia and the safety in Zambia. And then recognized the need to look at what we were going to do with children, particularly that were negative for malaria, but had other illnesses, particularly pneumonia and diarrhea, and moved into the area of integrated community case management. As Karen mentioned, we had a program in 4 countries as well, funded by CEDA, which was implementing ICCM, as it's called, at large scale in those countries, and just finished last year. That work continues, but broadening it again, looking at what else can be added to that platform and what makes sense to be added to that platform. And a good example of that is the inclusion of the management of nutrition in ICCM as part of our South Sudan program, and we call that ICCM Plus. And as mentioned, there's also the possibility to look at management of neonatal care and how that links also with community delivery of NTDs. Then if we look at prevention and control, what we've been doing at community level there, we've been focusing on distribution of nets is a good example. Obviously, you need community volunteers when you do the campaigns. That's quite an important element. But then in more recent times, as James also showed you, the importance of continuous distribution channels, and again, looking at community networks, for example, community volunteers that do the mass drug administration for NTDs, and how they can also be a source for nets continuously in the community. Seasonal malaria chemo prevention, we haven't really touched on so much yet. That's something we started in northern Nigeria, and as you all know, that's treating children during the malaria season to protect them from malaria. And we're, as I said, have started in northern Nigeria already, and hoping to extend to a larger program across 7 Sahel countries. And as I mentioned, mass drug administration for NTDs, we have quite a lot of experience of doing that in South Sudan. And then sort of cross-cutting aspects of it that we also have been working more and more on: community engagement, how you can do effective monitoring and evaluation of your activities at community level. And again, coming back to that same approach of using operational research to keep informing the design and the approaches used. And I think mHealth, the use of mobile phones, is something that's particularly relevant in terms of community-based deliveries, because mHealth has the capacity to really address some of the issues, as Karen already mentioned, in terms of data management, but also motivation and supervision at that level. So I wanted to just share some learnings with you. There are a lot, and apologies for the many ones I could also have mentioned, but I've tried to kind of focus on learnings that are really based on our experience and what we learned from what we've been doing through these programs. The first one is connections, strength, and delivery, and essentially I'm talking here about integration. So the need to have a harmonized approach to involve all stakeholders, as well as the Ministry of Health from the very beginning, to have a harmonized approach. And these are some community volunteers training in ICCM. The program that they're using was developed in a technical working group in Uganda, bringing in all the partners, implementing partners, the Ministry of Health, other experts, WHO, etc., to develop the training materials that was informed not just from Uganda's experience, but from what was available in other countries. And if you look at the links between the health services and the communities, really one of the things that's really critical is involving the health service in any community-based intervention or initiative, and particularly with ICCM, we from the very beginning, we used the peripheral health facility workers. They were used in the training, and they were also used as supervisors for the community health workers. And this has helped for the community health workers to feel more supported, and also to help with the links between the health service and the communities. And this was already mentioned, which is quite nice. One size certainly does not fit all. So whatever you are doing, you really need to understand your context, and whatever intervention you're trying to do, it's really important that you inform it from what's in the context. So many of our programs have got start with formative research wherever that's possible. This is a photograph from our seasonal malaria chemo prevention program in Nigeria. The formative research that we did showed very clearly that people felt that the uptake and the engagement would be stronger if the delivery of the drugs was done household to household instead of using fixed point delivery centres. So this is what was happening here. And then making sure that your materials are relevant and adapted and fit with the context and where you're working. Using ICCM again as an example in South Sudan, where you have quite a low level of literacy, using these red triangles, training the community health workers, the CDDs, doing ICCM, if they had a child that they recognized the danger signs, rather than trying to take the time to write out the note, the referral note, etc., that they would give the child this red triangle, and it was understood with the health facilities this was an urgent case as soon as they saw the red triangle, so it worked quite well. They didn't really need any more information, so bringing it down to what works and what's needed. Again, I'm afraid I have a lot of ICCM examples coming from my experience, but this is from Uganda. So what the community health worker has in his left hand is a job aid that is laminated and very pictorially and clearly with numbered steps guides him through how to do a consultation with a sick child. And the advantage of this is it's very clear. He can see what he has to do very quickly, but he can also write on it with a marker as he's doing the consultation. And then later, when he has more time, carefully enter the details into the register, which is what he's doing there. The community need to lead, they need to feel engaged, and they need to feel that they own whatever the program is. And from the very beginning, it's definitely, in our experience, worth investing before you do anything, before you reach the communities with anything, that you do extensive sensitization, presentation, explanation of what it is you want to do, so they feel that it is their program rather than something from way outside. This is a picture in Western Uganda of a village meeting where they are voting who is going to be, which members of the community will go to be trained in ICCM. So you can see there, she seems to have a lot of support, if you can see the hands there. So it's very much the community deciding how it's going to happen in their own community. And then building on that, very much the working with the communities to build their capacity to make their own decisions about their health. And we have used the community dialogue quite a lot in our work with ICCM and now moving it into NTDs. So these are partly facilitated dialogues, but only at the beginning in terms of training the people leading the dialogues, usually the community health worker, or sometimes the health facility worker, or the community leaders, to a dialogue which is guided in terms of mentioning or introducing the health topic. It could be malaria, it could be pneumonia, but then the community is talking about their own experiences and debating and deciding together what they as a community should do when their child gets sick with malaria, and with a little bit of guidance coming up with strategies or understandings that will promote better health. And in Asia, we have gone almost a step further. We have this program using the positive deviance approach in Cambodia, where you have community members that serve as role models to promote improved health-related behavior in their own communities. Maintaining quality is certainly a long-term commitment, as James clearly said. Training and investing in training, and training that is adult-focused, participatory, is very important in terms of getting the message across at the beginning, but you do need to also support supportive supervision. And you see a supervisor walking back home here from visiting one of the community health workers delivering ICCM. But it's a challenge. I mean, supervisors also need to be supported to do their work, and there can be simple things like, for example, through the Clover program, we supplied motorbikes to the health facility staff, the smaller health facility staff in Ethiopia, and I think other countries, with this photographs from Ethiopia, just so they could do their outreach work. They had a practical means to do it and also communicate with the higher level health facilities. And then the need to really ensure that you support the monitoring, the data collection from your program. There can be many different ways of doing that. We did a lot of training for HMIS and use of HMIS in Clover. We also supplied computers to peripheral health facilities to facilitate them to manage their data, enter their data, etc. When I showed this photograph to James, he laughed at me. He said, "You know, it didn't work." And I said, "Why?" And he said that we didn't give them the antivirus software. So we did learn from that. And the next time we did supply computers, we made sure that the budget also included the antivirus software. So really looking at the real obstacles and trying to address the issues. And this is just to say the designing of programs in the very beginning needs to include evaluations such as household surveys, as is happening here from Cambodia. And again, coming back to the need to look at what's there and make sure that what you do and what you have is evaluated and really rigorously field tested, piloted, etc., to fit the context and understand what happens in reality when things get out there. If I use the example of diagnostic tools for pneumonia, which really enabled the possibility to include pneumonia at community level in terms of managing childhood illnesses. So this timer it actually originally was distributed by UNICEF, but it's a very simple timer. You press the button and it marks until 1 minute, and then the community health worker counts the breaths. They look at the breaths, but the ticking of the timer sometimes ends up being what the community health worker counts. So we had a lot of challenges with that. We also looked at a much more simple approach using beads, colored beads. So every time the child breathes, the community health worker moves a bead, and if they go beyond the threshold, they'll go into the red color, and that should indicate that the child has fast breathing. But again, you need a timer with that. So one of the things that Karen and in her research with her groups is looking at are things like now you have apps that can be put on mobile phones as respiratory timers, and the feasibility with extended use of mobile phones, how that could be applied at community level. You might know what your strategy is. The inclusion, as I mentioned, of nutrition at community level and ICCM, the guidelines are already there, but really fitting them into the context in Wheel, in Northern Barra-Ghazal, was a process of trial and error, really looking at what model would work, what kind of support was needed, how to make sure the plumpy nut was there, how you made sure that you had a service that the community would use. And the strength of this is the fact that by having it at a community level, that the parents can keep the children at home, and it's much easier for them to follow the whole program of feeding. And then using mHealth, and we started with a pilot in the CEDA program, very straightforward, small pilot, using mobile phones to send SMS with the results from the register. So this was sent by the VHTs every week. And the findings from that, the kind of challenges involved, helped to inform a more elaborate evaluation that Karen, through her InScale project, is doing right now in 2 countries. And just to mention also the use of mobile phones as surveillance tools, which is happening in Cambodia using community networks, but I know Sylvia will address that one in more detail. So how has all this changed the landscape? I just wanted to show a few examples of what has happened as a result of this work. Coming back to the whole introduction of RDTs in Uganda, we, as part of moving that policy forward and working with the Ministry of Health to develop the diagnostic policy, we organized and facilitated 2 consensus workshops where we brought together WHO experts, both in-country and internationally, other experts on diagnostics, with academics, with MOH, and with implementers, to really look at the evidence and to inform the development of the policy. Also, similarly, in Nigeria and Uganda, our experiences have helped to inform the national ICCM guidelines in South Sudan. That nutrition program has really been adopted, and in fact we have some funding to continue ICCM in South Sudan from DFID, which was extended to include the nutrition component when they saw, partly based on the results of our program. And then just to go show you some areas we're working at global level related to this work. The WHO manual on universal access to malaria diagnostics builds up from this. The ICCM evidence review, which is happening at the moment, and there's a symposium next week in Accra, and we're very much active partners in that. Members of the Global ICCM Task Force and Operational Research Group, Pneumonia's Innovate. Anyway, you can read all of this here, but just to show where it's all going, and the continuous distribution model linked with campaigns, how that has, that really influenced the WHO recommendations. So I'd just like to finish with some areas that I thought were key priorities. in this that I wanted to raise, the whole thing of integration, what's feasible, how much can be added onto a program, and what's the scope. The use of technology, I definitely think mHealth has a lot to do in terms of strengthening the delivery of health services, including also being used as a tool for motivation of health workers. And really something I think that does need more investigation. How really do we reach those children that I showed you in the first slide? How do we get to them in a sustainable manner, and how do we ensure that the health service and health delivery is high quality at all levels, including right down to those children? And then coming back to the community aspect, something to be considered, what is the long-term role of community health service delivery in the long term as the economy strengthens in a country? What should that look like? And understanding the economics of health service delivery through the various channels, and really looking at that and comparing models more effectively. That's it. I think I went a bit long.
Thank you very much, Helen. Are there any immediate questions of clarification for Helen before we go into, just to encourage you, if there are any bigger questions, you can park them till we've heard from the panel. There's one here.
Thank you, John Paul Clark from the World Bank. Helen, thank you very much for the presentation. I was making some notes during it about things I was thinking about, and you came to them in the end in your summary slide about priorities for the future, particularly when you were talking about integration and the long-term role of community-level services. This is an issue that I was wondering if you had any more thoughts on, or perhaps other people in the panel will have thoughts on, about what's actually happening as more and more interventions and services are trying to engage community volunteers, community health workers. We have different names for the people that we are engaging at the community level, but often I'm seeing situations where there are programs that are almost in competition for the time of these people. And one of the issues that has become very important in terms of planning and program implementation is the question of the incentives and the motivations, and how that can be harmonized and integrated in a way that a community volunteer has a work plan that takes into account all of the different competing interests of the community and all of the needs of the community and all of the different types of motivational payment. Are we creating a new professional cadre of community worker? Is this a change from volunteerism as we've noted in the past? I was just wondering if you had any thoughts on where that's heading and maybe where that should head.
I think you picked an easy topic to start with, not really, but I think it is a very, very topical issue, and I think there is not an easy answer. But what I have observed happens, there's almost a pattern. So you see there's an issue, you can't reach the peripheral people, so you create a program, or a partner comes to work with the ministry to create a program that is a volunteer program typically, to extend the reach. And then over time there's a feeling that it's how that's going to go, and the Ministry of Health usually then, what seems to happen is they then look at a new strategy where they create another cadre, which is meant to be a community level, and often works from a health post, will have 6 to 9 to 12 months training, and typically will get paid. And that's what's happened. You have the health extension workers in Ethiopia, for example. You have the APEJ in Mozambique, who are not in a health post, but they do get a subsidy. And in some other countries, South Sudan is also looking at that model, and so is Zambia. But it's not really feasible for that model to get the reach that you have with the volunteers. So you then end up again with a gap. So I'm not giving you an easy answer, but I'm just recognizing that there's almost like a cycle here, and how they can fit together is something that I think needs an awful lot more exploration. And the scope of what the community health workers do in terms of their workload, that's one aspect. What is feasible, what's fair to ask somebody to do if they are a volunteer is quite important, and there's more research being done on that. And I think community ownership and the community making those decisions is something that needs to be explored more. And then coming to maybe the possible change in the role of the community health workers over time, which you also alluded to a little bit. I would like to think as health services become stronger, economies become stronger, that can move back more into being a health promotion, health prevention role rather than a a curative role. So they're just some ideas thrown back at you.
Thank you. No, I think you touched upon some of the key issues in your one question. You've addressed anything from role of community health workers, integration of services, incentives and motivation, etc. So I think it was a good question to start off this panel discussion with. So, and I'm sure some of these issues will be addressed in the remarks by the panel members. And I think we should start off the remarks from Nicola and hear what her reflections are.
Yeah, thanks for the great presentation. DFID and the UK has a wide range of programmes and partnerships with the Malaria Consortium, and you're a significant contributor to our results framework. So these presentations have been really welcomed, and in particular we welcome the learning and the papers that you do on that, as do our health advisors, so thank you. I normally get to follow on from Bernard whenever we do a presentation. I normally just get to say I agree with everything he says. He's on a different panel this time, so let's see. I think there are a couple of things that we all know. We all know that human resources are the biggest expenditure of any health system. We all know that the greatest proportion of people who have fever treat themselves at the community level. And we all know that there aren't enough fixed point facilities to provide care for all. And so there is a big role for the community and community health workers to play in that. But I think there are a number of opportunities, challenges and risks to that. And I don't think it's particularly changed very much over 10, 15, 20 years. And I think we're still trying to seek solutions to many of the issues that John Paul just raised. I think I'll try and limit to a couple of points because my other guest speakers will also be speaking. I think it's important to note that some of the weaknesses that we have in the health system will play themselves out when you've got community health worker programs. And unless we really look at that whole chain, we're undermining our potential for success. And I suppose the clearest one to bring out are around the supply chain in terms of RDTs, in terms of drugs, and in terms of nets. And we all know that stockouts is a major problem in health facilities. It still plays itself out when you're working with community health workers. And when you get a stockout with anyone, and someone goes to seek care from that person and they've not got the commodity, a certain level of trust is then broken, or confidence in that system. And so there is still this inherent weakness that you need to address across the health system. I think the other issue is around, and it lends itself to John Paul's point, was around the ambiguous nature of the role that community health workers play within the health system. And there's community health workers often demand a much more formal standing and cadre and recognition than this informal, you're just a community health volunteer. And I think there's still a lot of learning to be done of how that's been addressed in different countries. I think related to the health system again is around, intuitively we all know that that community health worker programs have a massive role to play in reducing pressure at both primary and secondary healthcare. When we were doing the evidence overview paper for the basis of the Malaria Framework for Results, our strategic approach to tackling malaria, we actually found very little peer-reviewed evidence around the evidence around that, around the cost savings, both in terms of health worker and drugs, and releasing space for other treatment of other diseases. And I think it's really important that we get on top of that, because that's going to be quite a strong argument for supporting these programs in the future, but also identifying where there is scope for more cost-effectiveness gains and efficiencies to be made. So I do think we need to get better at that. And I think, you know, the work that you're doing on SMC potentially is one of those areas where you really need to make sure that's built into your programming. I think the other area is around, in the same way we don't want to overburden systems, we want to release that. I do feel sorry for a community health worker. I mean, we're pretty demanding. We ask them to do so much with often very little incentive. And would we do that in our own country? I don't know. I just think we need to get, we still haven't tackled very well the whole issue around compensation, reward and incentives and the right level for the right amount of responsibility. Recognising that they also need to still earn an income for their own household. So I'm raising lots of questions and not many answers. But it's just, I think this still continues. And with integrated community delivery systems, I mean, definitely it creates efficiencies without a doubt. But to what extent is that possible without overburdening the community health volunteers? And also, where is there a demand for actually having a very specific role for a volunteer, rather than it being a multiple tasks? I think the issue around, I'm nearly wrapping up, the innovation side is really interesting, because it adds, it's moving quite fast now, having been stagnant for quite a long time, this issue. It's got the potential to move quite fast in terms of the move to, again, management of fever, looking around at the different types of innovation that can be done. What that means in terms of retraining and retraining and retraining, and how the fast pace of that, and how are we going to keep on top of that without confusing, without having the system break down in quality. I think that just adds an extra challenge. And I suppose my final point was just again linking not just to the terms of prevention and treatment of malaria, but actually getting a better handle on the caseload at community level, and how we can get much, much better in capturing the data on morbidity and mortality that happens in the community, in order that we can be better informed about how we allocate resources, how we build these systems, how we connect it to the health system.
Right, thanks. All very important points. Maxwell, what do you think?
Thank you very much, Chair, and Helen, for the excellent presentation. I don't want to bore you all about telling you why Nigeria is a bit important in the fight against malaria, because you probably already know. I also don't want to bore you about the challenges, because a lot of them might be highlighted by Helen, and most of us are familiar with it. I don't also want to queue behind you to say I agree, as you agree with Bernard, on most of your comments, because I actually agree with most of them. But I would like to raise some issues vis-a-vis my experiences in following up with a lot of the issues that we are talking about here. And I might disappoint you by not saying having a lot of solutions, but talking about questions. But I will attempt to tell you some of our experiences too in doing this. We have been able to reach a level in Nigeria that working with the community and trying to link them with the health systems has become very, very important, not only because we want to achieve high coverage, we want to maintain, we want to have impact, we want to be moving to the issue of elimination possibly. We also want to defend the investment that has gone into all the progress we have made. And as you know, we don't only talk about size and scope when we do these things in Nigeria, we talk about the complexity that is involved. And if all the huge investment that is there, God forbid, had to be lost, I think we will not, it's not a good thing. So in rolling out SMC, LLIN, and all the things we've talked about, I'm just thinking, is it the time for us to be sitting back and be looking at what are the efficiencies that we can be gaining in the rolling out of these programs, integrating ICCM with SMC, with Mass Drug Administration of NTD. There are ways that these things can be coming together. There are ways in which we can now be focusing more on the issues of value for money. People are talking about government bringing resources into what we are doing, which is good, but also the resource that we currently have, how can we make it to do more than it currently is doing? And you will be looking at all the ramifications. How do we want to start looking more? I know people will be talking about the issues of attribution, moving away from the output for us to gradually be looking at outcome and the impact of what we are doing so that we can keep the focus on this and see that we are actually winning the war against these diseases. Again, all the things I've said and what everybody has said in terms of lessons we've learned, I think we all need to recognize that it means that there's a transition that is going on. And what I mean by transition is that it means that the government, both at the national, at the state, and at the local level where we work, have to start learning to do things differently. What I mean is that it means that the way you do LLIN campaign, you just have a team of people that distribute the campaign and go away. Yes, you can do that and come back home. You are trying to start moving to a situation in which you have to routinely and continuously support a system that provides these services on a routine basis to people. And what they might be providing might be different in one context than the other. And how do you start changing the way this government respond to this in terms of linking the care, we call it continuum of care, from that very level towards the former formal health systems that we used to know. It also means how the donors, the partners, are working with various governments, how programs are being designed. You come in 1 week, 2 weeks, 1 month, you design a program, but how do we make sure that we actually capture various nuances in the communities to be sure that we're actually addressing the issues that needs to be addressed? I would also like to flag the involvement of private sector here. We all know that we cannot achieve universality and coverage that we're talking about without private sector. But who are these private sector? We need to start understanding them better. We need to start understanding what are the incentives for them to get into the system. We need to start understanding what are the incentives. I'm very happy we are talking about how to bring them in for the purpose of innovation. Can they be useful in addressing the issue of access to commodities so that at least it reduces some stress from government and all supplying the formal procurement supply chain system? And I'm also glad that people are talking about the issue of volunteerism within the community. In this, I will like to say it's very complex, but also I would like to remind us that are we not running too fast to learn from what are some good examples that we've had in the past? I can talk about Nigeria. Actually, the cadre of people called voluntary health workers actually started as voluntary. What made them change to the issue of now requiring money before they do what they are supposed to do? I think it's food for thought that would like us, and I think there are examples like that in all the countries, for us to go back, investigate what actually changed, and for us to be possibly, for us to be able to retrace our steps. Thank you very much.
Thank you very much, Maxwell. Again, many important questions and issues food for thought. Franco, do you have any answers?
I'm not sure. Well, first of all, I wanted to thank Malaria Consortium for inviting me to this panel discussion. I know most of the senior staff of Malaria Consortium now for many years, and I have learned to appreciate the way the consortium is working. On the issues here, okay, maybe I can start from this last point that was raised by John Paul, paid cadre versus volunteer. Obviously, I don't have a solution. We know how the different approaches, how countries have found different approaches, ranging from paid cadres, like in Ethiopia, like in Malawi, to purely volunteer approaches, to mixed approaches. Some countries have both, the JHUs and the role model mothers in Nigeria, the Agents de Santé Communautaire and the Relais Communautaire in Senegal or other Francophone countries. I don't know. I don't have the solution, of course. But if I have to really choose one way, I think I would opt for improving the volunteer system, because I think that if we move towards paid cadres, we would miss the key element of community case management, which is having a member of the community that lives next door providing the treatment for the diseases. Somebody from the same community that the mother can easily approach and talk to. In some countries where they have opted for the paid system, we end up having a person, they become practically health staff on a payroll. So you may end up having a person from the south living in the north. They don't sometimes even speak the same language. I mean, there are risks. Of course, overburdening the volunteers with more and more tasks. And nobody now in 2014 is ready to work for a T-shirt and a cap and a bicycle that is not working anymore after 2 years. Sure, so we need to develop more effective, maybe modern motivation scheme, but the fact of having somebody from the same community that the mothers can approach easily, 7 days of 7 next door, is an element that we should not miss. Otherwise, it's not community case management. Another argument that has been discussed is this dualism. Somebody said it's a false dualism, absolutely, between disease control programs and health system strengthening. I could not agree more. There is not such a dualism. There is no effective community case management without an effective health system. The two things are too much linked. I think one of your slides, Helen, showed this very well. And we know this out of experience in countries like Rwanda, for instance. They have really shown how community case management works better in the districts that perform better from a health system perspective. The implication is, in my view, also then when we then talk of projects, probably there should not be, so certainly my opinion is that there should not be a community case management project without a health system strengthening component, and vice versa, there should not be a health facility-based project without a community case management component. The two things are absolutely linked. should continue to be linked, and if we want to achieve impact, Millennium Development Goals, etc., they should be implemented hand in hand. Maybe my last point that I had noted is, challenges for the future. In my view, the biggest challenge is having policymakers in countries not only adopting the community case management strategy, but really scaling it up and taking ownership of a large-scale community case management program. It's a challenge because there are understandable concerns, the resources. I mean, you don't implement a large-scale community case management program without resources. You need a lot of money to do that. Another concern is a bit the lack of strong evidence of the impact and of the cost effectiveness of community case management. It's true. I mean, many of us have been working for years and years. Still, this impact is not, the evidence base for the impact is not very strong. We should ask ourselves why, after so many years, we still don't have really solid evidence of that. But the truth is that, we don't have it, and policymakers may understandably be a bit concerned about this. Most of the ICCM programs that are, or interventions that are currently being implemented in countries are donor-driven. And we should ask ourselves how to move out of this, how to make them Ministry of Health driven instead of donor driven. There are probably several reasons why most of the programs are donor driven, but we need gradually to move away from this scheme, because donor driven programs are by definition not sustainable. They have a beginning and an end. And I have seen, unfortunately, so many communities in countries being deprived of the intervention after 3-4 years. The project goes away, and the community is there, back to square one. We need to work on this. Not a solution, but a partial solution is maybe what we are doing now in WHO. We have a project funded by a donor, but we really try to associate the Minister of Health and involve it in each step of the development of the program. This can help in part to let them have ownership of the program. But the big step is, of course, the resources. We should consider giving the resources, I think, to Minister of Health if we really want them to then take over in these programs. Thank you.
Thank you, Franco. Now, are there any questions from the audience or from the Twitter feed? Diana?
Thanks. We have 2 questions from the Twitter feed. If you don't mind, I'll ask them both and you can decide how to use them. The first one says, in conflict areas like South Sudan, how are you ensuring that ICCM does not turn more harmful when supervision can't be ensured? And the second question is, CHW challenges identified, is it not time to involve the private sector, which often sees more than 50% of sick children, even when CHWs are present?
Great. 2 good questions. Maybe, Helen, would you like to comment on South Sudan and how we managed in a post-conflict situation to ensure supervision?
Or not.
Or not.
That's a very pertinent point. We had 2 ICCM programs running in South Sudan. One continues to run in northern Bahr Ghazal, but the other was based in Unity State, which, as you might recall, had a lot of security issues within a year of the Declaration of Independence. And it escalated, particularly around that area. It started with a lot of rebel activity, and then was with Sudan, between Sudan and South Sudan, and it came to the point where the roads out of the town where we were based, Bentiu, had landmines, fresh landmines. In fact, in the very end, after we had already evacuated, the town was bombed. So it became increasingly challenging, and we really tried at the beginning to continue. We had a network of supervisors who were continuing to go around to do their supervision activities with the CDDs as planned, once or twice a month. We're giving supplies, we're to the CDDs, bringing back the data. But we became increasingly uncomfortable exactly for that reason, because we couldn't get out there ourselves, we couldn't do our own assessment, and this was a relatively new program, it wasn't well established, so we didn't have enough knowledge or familiarity with how it was working to have the confidence to continue. So in that setup, we had to pull out and stop, because we couldn't guarantee that we could do supervision effectively. In northern Bahr Ghazal, which has generally been calmer, and we've had an ICCM program running there since, I think, 2009 or 2010, started with home management of malaria. And we've had more success there in keeping it going. Of course, with the problems again recently, we did have to pull out, but we had more community volunteers there who were able to keep a kind of skeleton service going. And we're just looking now, as we've just managed to go back into a wheel in those areas, what has that meant, and to follow up. But once you have that issue, you really need to look, when you have the opportunity again, what you're going to do to assess the quality. But I think it also opens up the area of looking more and more different supervision models that you can use, and particularly looking at peer supervision models and how that can be done. So you don't need such an external influence to make the supervision happen. And then, as I mentioned earlier, certainly it's going to become more and more feasible, I believe, to use things like mobile phones as not a complete substitute, obviously, for personal contact, but certainly as a useful tool for supervision. Yeah.
Thanks, Helen. And this kind of relates to Franco's comment about should we do ICCM in areas where there is no health system to support it. And of course, that is sometimes a bit of there's a balance of what benefit you get. The other question was around the private sector, and I think I'll turn to Franco for that one to hear his thoughts around the role of private sector in community case management, and is there good examples of where programs have managed to implement ICCM linking to the private sector?
Well, I know that there have been projects, I think in Uganda, you must be aware that there was one, and they have achieved certainly some results. My personal opinion is that, of course, we cannot go large scale without the private sector. This is a fundamental question. I mean, if we really want to achieve large-scale community case management, the private sector needs to be involved. We need to develop a way to involve the private sector and at the same time ensure good quality. I mean, the quality of the management that the private sector is able to provide is, in my view, the weak point. We need to understand the different motivations that drive a private vendor. He's not a volunteer. He has never wanted to be a volunteer. He needs to earn the money for his family. And at the same time, we need to balance this with our needs, that community case management is an effective tool, but it is not just dishing out drugs or dishing out diagnostics. It's managing a sick child. So we need a certain minimum level of quality. The two things need to come together, and it's a huge area of work.
Indeed, and I think maybe just to add to that, I think one of the things we've seen in our ICCM programs, in particular in Uganda, is that with ICCM, at scale, we actually get much less private sector use, that caretakers now tend to prefer to go to the community health worker rather than to the private sector. Nicola, you had a comment to make?
Yeah, I think it's just in, partly the question, the answer depends on what type of private sector you're talking about. But if we're talking about the informal private sector, there are initiatives that are underway. The AMFM was all about scaling up use of ACTs in the private sector, and there are now projects that are trying to scale it up alongside use of RDTs. The questions are around adherence and around the incentives for that. And it is a service and intervention. It's not selling a commodity over the counter, so it is quite complex. DFID is supporting PSI to do a project in Burma where it's scaling up ACTs through private sector outlets and is piloting what sort of incentives will work around RDTs. So there's a lot of work going on. There's quite a lot of learning to be had, and that needs to be pooled quite quickly in order to support that. The other question is still always going to be about what to do about non-malarial fevers. So if you don't give them an ACT, the next default position is around antibiotics, and hey presto, we have antibiotic resistance. So we do need to solve them both rather than looking at malaria in isolation.
Absolutely, and hopefully we have a great opportunity now with the Unit Aid project that we do together with PSI, which will address not only RDTs in the private sector, but also the case management of non-malaria fevers. Franco?
Just a small point, because this has, with regard to non-malarial fevers, I must say, and you may be surprised to hear these words from me, I'm working for the Global Malaria Program at the WHO, but we don't recommend any more community case management of malaria only. We don't think that this is a sensible way to go. In the era of RDTs, community case management must be integrated of at least the 3 basic diseases, or I have learned today also ICCM+. Without an integrated approach, you don't end up limiting misuse of ACTs, and you don't provide treatment for other major causes of disease. So I can say here now the current view of the WHO Global Malaria Program, please not anymore community case management of malaria only, but integrated.
Are there any other questions from the audience? Yes.
Thank you. Elizabeth Bluntirian News. I would like to follow up on what Helen was saying about South Sudan, and thinking there's been quite a lot of turmoil recently there and in Central African Republic. Yes, you had to pull out of one of your projects, but are they still more resilient than Ministry of Health formal care and management?
I would say, put quite simply, yes, because there is very much partnership there. For example, Malaria Consortium is based in the Wheel. I don't know the names of the other implementing partners, but I'm sure you're very aware that the health service in South Sudan has still got a way to go to build up, especially in the peripheral areas. So you have a lot of health posts and health facilities that literally have no staff in them. Some of them don't hardly have a building, so it's very much about working in partnership with the Ministry of Health to build that up. And at the moment, I think the partners' presence is really making health service in those areas more realistic and a reality. Yeah.
Yes, please, Neil.
Neil Squires from DFID. I've just been reading a couple of your learning papers here, and one's very interesting, encouraging communities to talk. And this actually makes the point that you need a dialogue with communities in addition to community health worker interventions, because there is information asymmetry in health. And one of the key challenges working with communities anyway is to get them to use and have appropriate expectations about health services, but they also need to have appropriate expectations about what community health workers can and can't do. And it really should be communities that hold their community health workers to account. So I think these are two very useful papers. The other point to make is obviously that there have been a couple of systematic reviews on community health workers and what they can and can't do. And the key messages are that community health workers can do certain things well if adequately supported, supervised, trained, and with continuing professional development to ensure that they maintain those skills. And it's these key principles that we need to be emphasizing. And the other point, obviously, is that community health workers should only be developed within the context of a comprehensive human resource strategy. So the government needs to have oversight of the development of these. And I know that the Malaria Consortium worked with others in Mozambique to ensure that there was coordination between a multitude of different initiatives to train community health workers. And in the last panel presentation, we heard about the importance of alignment. And clearly this is critically important because one of the problems with donor-driven initiatives is that there's a proliferation of different activities. And unless we work together behind government-led initiatives, it will be very difficult to coordinate and ensure effective monitoring and supervision within the context of a national strategy for human resource management. So I think there are some important messages there, but I particularly wanted to flag the value of these learning papers and the importance of community dialogue.
Right, thank you. There's a comment here. Yep.
Robert Seabrook. I'm a lawyer, so I'm on a learning curve, but having just spent 3 days in Uganda, I am, of course, now an expert. But could I just say that one of the things that really impressed me in this recent visit was the educational side, in seeing in a primary school malaria prevention and early reporting being really delivered as a powerful message by notices in the playground, teaching, posters on the walls all over the place. And when you're talking about sort of an integrated system involving government and private sector and all the rest, isn't education something that should be flagged up really high? These were primary school children, and you couldn't help feeling that they go back to their parents and say, why haven't we got nets? Or, and have quite a considerable influence over a continuing long period of time. There's just a layman's thoughts, and I wondered what the panel thought about that.
Anyone wants to comment on that?
Yeah.
Maxwell?
Yes, I think it's a very important thing you've brought out, and one of the continuous distribution channel actually of early line, and that we have tried out in Nigeria, is distribution of early line through the schools. And the main objective is how you can use schools as a method of increasing the supply of early line to the household, which is different from if you give nets in a boarding school. So these kids go to school, go home with their nets. Not only that they are given the net, but they are taught on the advantages of sleeping on that net and so on and so forth. And from there, they start asking their parents other questions. Why are my siblings, other siblings are not sleeping on that net, and how can we get new ones, and so on and so forth. And we see the private sector actually already even riding on that. And we are suggesting to them that they could even ride on it bigger than that. For example, the nets that we currently have are in very limited colors and shapes. Maybe they want to start producing one that has Mickey Mouse on it or wherever, so that children can be attracted to it and encourage them at early age to start sleeping on that net and encouraging others.
Great. We're slightly behind schedule, but we'll take 2 more questions. Yep, Killican.
Thank you. I'm Killican Olemoyoy from Novartis in the Malaria Initiative. I wanted to revisit this question about the private sector and to just maybe focus specifically on Nigeria, where roughly 64% of patients seek treatment for fever in the private sector. And I think Dr. Pagnoni's points are very valid, that there's definite concerns about the quality of case management in the private sector and the incentives of pharmacists. So just to clarify, by private sector, I'm saying licensed drug shops or patent medicine vendors. So is there an appetite to actually try to train these private sector retailers in malaria case management?
Yeah, next one.
Thank you very much, and I'm glad you used Nigeria as an example. The answer directly is yes. But I think more and more we need to define, when we just use the word private sector, who and what we actually mean. If we talk about the informal sector, like the PMVs, the drug workers, I think one of the first initiatives is to get them organized so that they have a face, and once they have a face, you can engage them. And training them, they are being trained as part and parcel of all the community service providers so that they can have knowledge of case management treatment. But also, we need to also engage them if the other community providers are providing these services free. Do you want to agree with them to be providing malaria and other pneumonia and diarrhea services free? And if the answer is free, how else should they make their gains and so on? This engagement is ongoing. But if you raise the level of the private sector you mean to mean formal clinics or hospitals, again, this needs to be discussed as part of continuum of care. If you map a community and the only sensible health institution that can provide, that can serve as a referral point to the community caregivers in that environment is that private hospital. I think we also need to discuss how that hospital will be able to provide that function, rather than ask community caregivers to refer to a public hospital that's twice the kilometer of that public hospital. And I will quickly then go to another level of private sector, which are the people that are trading in these commodities. I think a lot of time they have to make a choice between the increasing tendency, and I understand the reason why it's like that, for pool procurement, in which a lot of these manufacturers of LLIN or manufacturers of ACT go for international and institutional business. And they are a bit less concerned about retail market. And it's this retail market that actually addresses some of these. I can just walk across the road to go and buy net, or walk across the road to go and buy ACT. And how do we incentivize them to be interested? For example, there are so many different types of sleeping places that can determine the shape that which a net could look like. And it could be different in one part of Nigeria to another part of Nigeria, not talk less of one country to the other. How do we get manufacturers to be interested in this? Once they're interested, they normally have their supply chain. If it works, will this take some pressure from the public sector supply chain? These are areas that I think we need to still explore more. But the good thing about this is it brings innovation. It brings, people can bring in new products and actually take off. In fact, it's a sustainability strategy for a lot of donor spending, because once people can, although there are issues of equity, can people be able to afford? But again, you can argue that if many people are buying, then the prices can go down. If there's competition, prices can go down. It doesn't mean that even if it's 1 cent, some people can still afford. But then government and partner can concentrate on that very small percentage. Thank you.
Thank you. I know there's many questions in the audience still, but we have to break here, unfortunately. So I hope you can interact with the panel after the session.